Ever noticed your bladder acting differently during perimenopause or menopause? Well, you're definitely not alone, and today we're going to unpack why that happens. Here with us is Dr. Victoria Scott, a urologist specializing in female pelvic medicine, who has dedicated her career to helping women manage bladder health and conditions like interstitial cystitis or bladder pain syndrome. Together, we'll explore what's really going on during this stage of life, why flare ups can become more common, and what you can do to find relief and feel more in control. So, welcome, Victoria. Thank you so much for being here today. And
Thank you for having me.
yeah, this is a really interesting topic that does not get enough attention. And so many people are struggling with bladder symptoms, just urgency, frequency, pain, discomfort, and waking nocturia. So it'll be great to dive in and learn why this happens and what we can do to have some relief.
Yeah, absolutely. So as a urologist who specializes in female pelvic reconstructive surgery and urogynecology, I tend to see so many women, particularly at perimenopause and kind of early menopause time period. And so I have a particular interest in this time of life. I actually got additional training to become a certified menopause practitioner as well, simply because I felt like even with just my urology tools, I wasn't able to provide enough tools and medication options for these patients. So I definitely love that we're talking about overactive bladder, bladder pain, pelvic floor muscle issues, specifically for patients or women during perimenopause time. So I know you've had some practitioners already talk about perimenopause, menopause, what is it? But just to quickly review for anyone kind of just jumping on here. So menopause is actually just a time point in life, 1 year after a woman's last period. And before that is premenopause, after that is postmenopause. Perimenopause is the time period leading up to menopause, that last period. And the age range can vary pretty dramatically. Generally, it's like early to mid 40s, could be as early as late 30s, though. Average age of menopause is about 51, 52. So it's kind of that whole maybe even up to 10-year age gap or age range when estrogen and progesterone are really just fluctuating. And it's that rapid fluctuation of those hormones that can be pretty dramatic that can cause all these symptoms. Postmenopause, typically most menopausal symptoms that we think of, the hot flashes, the night sweats, the mood instability, typically will subside, but the symptoms we're about to talk about, the genitourinary syndrome of menopause, which are the bladder, the vaginal symptoms that are associated with the fluctuation and then drop of estrogen, these can actually worsen in the postmenopause time period. So they end up bothering women for a lot longer in life. So definitely important to talk about and be aware of.
Yeah. So, why is this actually happening at this stage?
So the urethra, the bladder, the vagina, and the vulva all are covered with estrogen receptors. So they love estrogen. And in the premenopausal state, there's lots of estrogen floating around in your body, and there's some fluctuations during the menstrual cycle. But in general, you have a good amount of estrogen in your body. And so these tissues are nice and healthy and happy. When we start to have the fluctuations and then the drop after menopause, we develop this syndrome we call a genitourinary syndrome of menopause. And so this includes vaginal dryness, painful sexual intercourse, urinary urgency, frequency, incontinence, painful urination, and recurrent urinary tract infections. What it's doing for the tissue, it's helping maintain elasticity so the vagina can stretch comfortably. And it's helping maintain the rugae or the folds in the vaginal canal, again, that help to make sexual intercourse not painful. It's also helping to maintain a good microbiome. It helps to keep the environment in the vagina nice and acidic, and helps promote the growth of good bacteria. So this becomes very important for preventing urinary tract infections. So overall, when the vagina, the urethra, and the bladder lose estrogen, they become unhappy, more dry, and uncomfortable.
So that must be a major problem for those struggling with interstitial cystitis because a lot of those symptoms are IC symptoms. So how do we distinguish between IC flare and what could be GSM, and what do we do in this case?
Absolutely, it can be very challenging, and that's a really good point for patients with IC to be aware of. I mean, unfortunately, women in general, most women are not very familiar with genitourinary syndrome of menopause. And so when they start to develop these symptoms, they have no idea what's going on. And then particularly for women with IC, um, the genitourinary syndrome of menopause can mimic IC. So as you point out, we have to figure out, is it just your genitourinary syndrome of menopause or is it your IC? But they can also make IC symptoms worse. And then they can introduce, recurrent urinary tract infections as well. So all of these things can be really challenging. I think that first of all, exam is very important, of course, for any woman going through perimenopause or menopause that does have IC. If you notice a flare, then certainly ask your urologist, urogynecologist to perform an exam. And we can start to see tissue changes that help us identify that they benefit from treating the GSM in addition to their IC. But I also always tell patients, look, early on during perimenopause, we still might not necessarily see tissue changes. And so it's never a bad idea if women are with IC are having worsening urgency, frequency, dryness, painful intercourse, to try therapy to treat GSM as well. Because it can be hard to diagnose. We don't necessarily have like blood tests to tell us, oh, you're definitely perimenopausal. We can tell, once a woman once their estrogen has completely dropped. But during perimenopause, it becomes a lot more challenging because the estrogen is kind of going up and down. So we kind of have to go more based on the signs and the symptoms.
Mhm. So what are we looking at treatment-wise?
So for genitourinary syndrome menopause, the best treatment is going to be vaginal estrogen. So this is local therapy. It's different from our systemic hormone replacement therapy, which can also be great and can help some of the genitourinary syndrome of menopause as well. But really, our best treatment is going to be the local therapy. So we can introduce estrogen with a cream. That's usually the kind of easiest, most common treatment to use. And this is a cream that you can use with the applicator that's going to go inside the vagina, but sometimes also needs to be applied to the vulvar tissue too, because sometimes we need more absorption there. And this is done usually 2 to 3 times a week. There's also a suppository, so some women feel like the cream is a little more messy, so the suppository can be a little easier to use. And then there's also a ring, which is kind of the least messy thing too. So there are options, and it's important to figure out, which you think will be easiest for you to use, because the most important thing is actually using it. And then I always advise patients, it takes time, so don't forget, we really have to give it a good, 6 weeks to see improvements. I see a lot of patients who start using it and then stop after like a couple weeks because they just don't like it and they don't really see immediate improvements.
Mhm.
And another thing I always have to remind patients about is it's something that we do have to continue kind of indefinitely. A lot of people will start using the therapy and then they feel great, they feel a lot better, so they stop, but then the symptoms come back.
Like antibiotic use when you don't finish your antibiotics and then the infection comes
Exactly.
back. What about on the holistic front? Is there anything for people who are
Yes.
sort of averse to using hormone replacement
Yeah,
therapy? And
absolutely. Yeah, so that's a really good point that we should talk about. And I'm sure you've kind of jumped into this with other menopause discussions, but a lot of women are still scared about using hormones. And a lot of this stems from the Women's Health Initiative, which was that big study in the early 2000s where they looked at, estrogen and progesterone as hormone replacement therapy and the possible side effects for women. So they actually stopped it early because they said, we're concerned that it's really increasing risk of breast cancer and cardiovascular disease. Now, so this led to obviously a pretty dramatic decrease in prescribing of any kind of hormone therapy because everyone was very scared. the great news is we're starting to look back at a lot of that data now and realizing there are many reasons that the study was flawed and probably not applicable to everyone. So many practitioners are kind of regaining a lot of confidence and being able to safely prescribe hormone replacement therapy for patients, which I think is fantastic because there's so much data to suggest that it really helps a lot of women. And I personally see that so much in my practice. So I'm very happy to be able to provide women with more tools now. So I would just, urge if you still have hesitations or concerns to really talk to your doctor, look up, more of the recent data we have now to hopefully convince yourself that if you need hormones, they can be very safe for most women. But just to kind of highlight a few of the reasons why the study was flawed and maybe not as helpful or accurate as we were concerned. The average age of women was pretty old. We're looking at around like 68 or so, and that's a lot older than most women now need to start hormone therapy. The type of estrogen, they only looked at one type of oral synthetic estrogen, so they didn't really look at some of our other options that may be a little safer, like the transdermal patches. So those are kind of the main things, and there are a few other nuances as well that are really important to understand. But just to provide some reassurance, don't necessarily hear the word hormones and get really scared about breast cancer or cardiovascular complications. But for the vaginal estrogen, it's great because very little, if any, is actually being absorbed systemically. So even if you say, okay, I hear what you're saying, but I'm still really worried about hormones, risk of breast cancer, you can have a little even more reassurance that it's really remaining mostly just locally in that tissue. But to answer your question, let's say some women are like, I hear what you're saying, I don't care, I still really don't want any hormones.
Mhm.
It's very reasonable to start with a non-hormonal vaginal moisturizer as well. So there are a lot of these options over the counter. There have been a few studies even on coconut oil as well. And these can be helpful. They're certainly not quite as good as the vaginal estrogen. And they probably don't have the benefit of preventing recurrent UTIs and really help reestablish the vaginal microbiome, but they can definitely help with some of the dryness. And possibly, some of the urgency and frequency too. So it's definitely not unreasonable to look at that as an option. In addition to the vaginal estrogen, there is a vaginal DHEA option as well. So this is like the precursor to estrogen and testosterone. And this can be a good option. It comes in the form of a suppository as well.
Mhm. And what about HRT? Like, is that
Yeah.
helpful as well for those struggling with like I'm just wondering, especially for the IC patients, me being one and approaching the perimenopause period, it's actually makes me quite nervous to I don't know what's going to happen and how my bladder is going to react. So is HRT safe for IC patients? And are you seeing a large benefit for those patients who are using it?
Yes. So, unfortunately, we don't have much data really confirming that you're not going to have a flare or you will with systemic hormone replacement therapy or even local vaginal estrogen therapy.
Mhm.
We do know that, so some people may have hesitation given the fact that estrogen may activate mast cells, for example. So they can lead to degranulation of mast cells, which is one of the prominent theories of IC, that some of these patients have too many mast cells that trigger significant inflammation and vasodilation and histamine release. So I could definitely see where some people may have some concerns there, but we really don't have any data to suggest that that's the case. I think I definitely hear your concerns. I see this in so many of my IC patients where they're like, I've finally figured out like how to control my symptoms. I don't want to introduce anything or change anything, which is a very valid concern. So I think it's just important for everyone to, you know, to wait until they really become symptomatic, perhaps with maybe it's genitourinary syndrome, menopause, but maybe it's also, the hot flashes, the brain fog, or other issues. So I would just urge people not to be too scared to introduce HRT if they really need it.
Mhm.
Because we don't have data that's going to make your IC symptoms worse in any way. And there are just so many benefits. We're focusing on like GSM right now, but other things to consider, other ways that menopause and perimenopause may make IC worse, could be sleep. Certainly a lot of women going through menopause have sleep issues, and that could certainly cause a flare in your IC symptoms if you're not sleeping well. With stress, can certainly experience increase in anxiety, depression, mood lability. And so these are other ways that IC could get worse.
Mhm.
There's also some evidence that the decrease in estrogen can decrease pain thresholds and centralization of pain too. So certainly that's another mechanism where IC patients could have worsening symptoms during menopause. So all these things really could be helped with HRT if needed.
Mhm. Are there stats on GSM? Like, do we know how many women get?
Experience it.
Yeah.
Yeah, based on survey data, it's a pretty wide range, but when they look at postmenopausal women, up to even 80% of women have been found to experience symptoms of GSM. So it's very common.
Wow.
And again, unfortunately, not really talked about. I think a lot of women, of course, are embarrassed, but also just think, oh, this is a normal part of aging. Like, I just kind of have to deal with. But they don't, because we do have some pretty good options to help.
Hmm. So, what about studies? Have we had any studies? Are there any new treatment options for IC patients specifically dealing with flares from perimenopause?
Well, as with everything I would say we definitely need more data and research looking at, how to best help manage IC flares during perimenopause and menopause.
Mhm.
There have been some small studies, specifically looking at GSM and treatment of that during perimenopause and menopause for IC patients, and they definitely see benefits.
Mhm.
Um, but again, these are smaller studies. In terms of new treatments, unfortunately, not really that I know of. But certainly, hopefully, people are continuing to ask these questions and look into it.
Mhm. You have a supplement line, Femetry, and how do these products help those struggling?
So, the product line was specifically designed for interstitial cystitis, but also can be so helpful for patients with other bladder symptoms. And I say bladder symptoms kind of vaguely because this could include urgency, frequency, or the recurrent urinary tract infections.
Mhm.
Um, so the daily bladder control supplement is great. There are lots of things in this supplement that help, again, IC, but actually interestingly, also menopause symptoms and GSM. So one kind of interesting ingredient there is pine bark. And there's not, I didn't really know that much about it. I don't think a lot of people talk about this, and specifically like the French maritime pine bark extract. But
Mhm.
there's actually a lot of research on the benefits of this specific supplement to help, again, with promoting gag layer, decreasing inflammation, and then also helping with genitourinary syndrome and menopause as well. So that's one interesting component. Also the UTI prevention. So the pine bark can be helpful for UTI prevention. There's another part of the supplement, the D-mannose and probiotics. Women of kind of all ages benefit from UTI prevention, but specifically around perimenopause and menopause time. Like we talked about, that decrease in the estrogen is really going to alter your vaginal and urinary microbiome to make you more prone to having the kind of bad E. coli and Klebsiella bacteria living in the vagina. So now it's easier to cause infections.
Mhm. And how does D-mannose work? Just so people, I think a lot of people are, some people are familiar with it, some people aren't. So just to let people who aren't familiar how D-mannose works.
Yeah, you're right. We hear so much buzz about cranberry, and cranberry has the active ingredient, the PACs, which concentrates in the urine, and then bacteria want to bind to that rather than the bladder lining. D-mannose acts in a similar way, but we find it's actually particularly good for patients with IC or do have more urgency, frequency, bladder pain issues because even the cranberry supplements can sometimes be a little more irritating, whereas the D-mannose is usually a little more gentle. This is a sugar that concentrates in the urine, and by the same mechanism, bacteria want to bind to that sugar rather than the bladder lining to cause infection.
Hmm.
So we really like this as an option for our IC patients.
Hmm. Yeah, because IC patients can't take the cranberry extract. It's too harsh, too acidic, and tough on
Exactly.
the bladder. What about nervous system support? How do you find that? Do you think is important as the hormones for symptom management?
Yes, absolutely. So we have lots of research that any kind of stress or issues with nervous system can absolutely flare IC. Now, interestingly, we kind of talked about a few mechanisms where, hormone replacement therapy can actually help your nervous system too. Um, again, like with sleep, with brain fog, also with that, if you are having increased centralization of pain or pain threshold, and your nervous system is decreasing, some women do find HRT helps. So some women, not just with IC, but fibromyalgia, migraines, other chronic pain syndromes can actually get a lot worse during perimenopause and menopause. And then some of those patients do see improvement with replacing the hormones to help the nervous system.
Mhm.
Um, but, it's certainly possible that perhaps, and this can be tricky right around that time period where it might not be the hormones causing, flares of symptoms, in which case, and if it happens to be more the central nervous system, then you do need like the TCAs or gabapentin or another more like nerve modulating medication to help your IC, of course, sleep, stress reduction, all those things too.
Yes, we can't stress enough, no pun intended, how important those are. Well, this has
Yeah,
been really, really helpful. I mean, we just basically summed it up in a really nice package so that people can really understand it because I think it's complicated. It's something that happens that we don't talk about enough. People, like you said, don't want to talk about it. It's one of those things, GSM, like they don't want to talk about the pain with sex. They don't want to talk about um, all the unpleasant things that go along with it. So thank you for doing this. This has been just great. And I think it will be a huge help to so many, really just made it simple for people to understand. And I thank you so much for that.
absolutely. Thank you so much for having me.